The other slow-growing mycobacterium that we'll talk about is Mycobacterium leprae, which is the causative agent of leprosy. There are two manifestations of leprosy. There's tuberculoid and leprodermatous. With the tuberculoid, it will look something like this, like on this patient's limb, where you'll see these kind of hypopigmented plaques, so plaques with like lower levels of pigmentation. There's going to be nerve damage, sensory loss, and in terms of the immune response, you'll see a lot of lymphocytes, but you won't really see a ton of bacteria here. The infectivity is pretty low, rather normal immunoglobulin levels, not a lot of rash. This isn't typically what we think of when we think of what leprosy is. When we think of like what leprosy is, we're often thinking more of the leprodermatous leprosy, where you end up with extensive tissue destruction. So the bones of the fingers, the cartilage of the nose and ears. There's going to be a lot of sensory loss, and you're going to have macrophages that have a lot of vacuolation because of the bacterium. And you're also going to be able to detect the bacterium in the skin lesions and in the internal organs. And this one is highly transmissible through touch. Now, I mentioned in the US, leprosy is not very common. It used to be more common. And there were these things called leper colonies where people who had leprosy were isolated from the rest of the population to try to protect the rest of the population from leprosy. In the US, the, reservoir host of leprosy is thought to be armadillos. So armadillos are infecting humans with leprosy, but we gave it to them first. Never, ever touch an armadillo. So this is a roadkill armadillo I saw in Texas, and you can see somebody thought it was a good idea to put a little beer can in his little hands, and hopefully they did not get leprosy. I did not touch. I just stood far away and took a picture with my camera. The other slow-growing group of Mycobacterium is this complex of Mycobacterium called Mycobacterium avium. These are really uncommon unless you're talking about patients who are immune compromised. And so here we have a case where you have a patient with advanced AIDS who died of a disseminated Mycobacterium avium infection. 27-year-old man who had a 2-week history of decreasing ability to breathe and a non-productive cough, so no sputum. The patient had pneumocystis. It's a fungal infection that's pretty common in AIDS patients in his lungs, and the serology confirmed that he had the HIV infection. The patient was treated with antibiotics and discharged. He showed up again a couple years later with the fever, difficulty breathing, developed severe chest pain, left the hospital against medical advice, but returned a week later with a cough, fever, pain in the chest and arm. It was suspected that he had pericarditis. So the pericardium is that membrane that surrounds the heart. So they suspected that he had an infection caused by tuberculosis that was inflaming the membrane of his heart. And they prescribed him mycobacterial therapy. However, over the next 3 weeks, he developed progressive cardiac failure and died. And it turned out that they were able to recover Mycobacterium avium from the pericardial fluid, as well as the pericardium, spleen, liver, adrenal glands, kidneys, small intestine, lymph nodes, and pituitary gland. So this bacterium went all over the body. Although Mycobacterium avium pericarditis was unusual, the extensive dissemination of the mycobacteria in patients with advanced AIDS was common before azithromycin prophylaxis became widely used. So the idea is that once patients with HIV were on antiretroviral therapy, it was more uncommon to see AIDS patients suffering from these types of infections. The fast-growing Mycobacterium we're not really going to talk about too much because they rarely cause disease. Generally, the infections we do see with the fast-growing Mycobacterium are caused by trauma or by medical treatment. They are resistant to most antimycobacterials because those drugs have really been designed to target the slow growers. However, because they're more rapidly growing, they are susceptible to other types of antibiotics. We have a case study here. So if you like to get your nails done, I'm sorry. A physician reported to the California Department of Health 4 female patients who developed basically infections like boils in their lower extremities. Each patient had small red bumps that became large, tender, full of fluid, basically big nasty boils over several weeks. Bacterial cultures at first were negative, but the patients failed normal antibacterial therapy. All patients had visited the same nail salon before the boils developed. As a result of the investigation, a total of 110 patients with boils were identified. A species of Mycobacterium was cultured from the lesions of 32 patients, as well as from the foot baths used by the patients before their pedicures. Shaving the legs was identified as a risk factor for disease. Similar outbreaks have been reported in the literature, which illustrates the risks associated with contamination of waters with rapidly growing Mycobacterium, the difficulties of confirming these infections by routine bacterial cultures, which are typically incubated for only 1 to 2 days, and the need for effective antibiotic therapy. So even though these are fast-growing Mycobacterium, they still grow slower than other bacteria. So you need to probably culture these for 4 to 5 days or a week or so in order to get the colonies to show up on a plate. And then hopefully you recognize that shaving the legs, so even if you don't notice that there are cuts or nicks in the skin, there probably are nicks in the skin, and that can allow the bacteria to get in. And so it's one of those situations where often if you're going to get a pedicure, you may shave your legs because you know the nail technician is going to be there. They're going to maybe give you a little calf massage, and you want your legs to be nice for them to do that, and you don't want to be all hairy or stubbly if that's your thing. And so then you end up with those nicks and that risk of infection. So as long as you go to a nail salon where they sanitize very, very well, this is probably not a risk. The other acid-fast genus that can cause human infection is Nocardia. These are just like Mycobacterium. They're aerobic, rod-shaped bacterium. They can form kind of these filamentous-looking structures that you can see in microscopy. Their mycolic acids are shorter than those of Mycobacterium. So remember, Mycobacterium has mycolic acids of anywhere from 70 to 90 carbons. So these are a little bit shorter. So they're what are called weakly acid fast. And the fact that they are acid fast helps distinguish them from another group of bacteria called the actinomyces. The actinomyces are also rod-shaped, and they can grow in these type of filamentous structures. So the fact that Nocardia are acid fast helps to distinguish them. Colonies on a plate don't necessarily appear consistent. So this is a pure culture, but you see there's some really tiny colonies, some that are larger, some that have spread a little bit farther. They're kind of irregularly shaped. It's not a consistent formation. And they can even sometimes, because of this filamentous structure, form these like hyphal type structures. So they can look almost like a mold on a plate, but it is actually a bacterium. These bacteria are able to avoid killing by phagocytic cells. They have an enzyme called superoxide dismutase, which helps them to detoxify reactive oxygen species. They also have catalase, which, remember, allows them to turn hydrogen peroxide into water and oxygen. Therefore, they are able to replicate in the macrophage. They can do a number of different things. They can prevent phagolysosome fusion. They can prevent the phagosome from being acidified. They can avoid killing by the acid phosphatase. they are very, very good at evading the immune system. These are generally considered to be exogenous infections. That means infections acquired from an outside source. Nocardia is not known to be a normal member of the human microbiome. So the infections are coming from outside the host. These are more common in patients who are immune compromised. Even though they're really good at avoiding the immune system, in patients who have a healthy immune system, they're far more able to fight these infections off. And generally, the manifestations of disease that we're going to see are cutaneous or respiratory. So that's described down here in this box: pulmonary diseases, bronchitis, pneumonia, lung abscesses, and then primary or secondary cutaneous infections. Eventually, if left untreated or if a patient is severely immune compromised, you could see these infections go to the brain, where you could see things like meningitis or brain abscesses. And here is a patient who has a cutaneous infection. So it's a pretty gross, gnarly looking skin infection that you would want to have treated relatively quickly so it doesn't begin to disseminate. With dissemination, so here's a patient, a 63-year-old man who had received a liver transplant because he had cirrhosis caused by hepatitis C. Anytime you have a patient who has received any sort of organ transplant, they are immune compromised because those patients are going to be prescribed a heavy course of immunosuppressive drugs to keep them from rejecting the organ. So the patient has been treated with immunosuppressive drugs. This is, I guess, 4 months now after his liver transplant. He returned to the hospital with fever and lower leg pain. Chest x-ray was normal. Ultrasound revealed an abscess in the muscle. Poorly staining gram-positive rods were observed in the gram stain of the pus. So because they have that like thinner layer of mycolic acids, you can sometimes do a gram stain on Nocardia, but you might want to confirm it with an acid-fast stain as well. Nocardia, they grow faster than Mycobacterium, so they saw colonies on a plate after 3 days of incubation. Treatment with imipenem was started, but the patient developed convulsions 10 days later and partial left-sided paralysis. Of course, that indicates that there might be some sort of neurological complication, and brain imaging confirmed that there were 3 lesions in the brain. Treatment was switched to 2 different antibiotics. The subcutaneous abscess, the brain lesions gradually improved. The patient was discharged after 55 days of hospitalization. This patient illustrates the propensity of Nocardia to infect immunocompromised patients and disseminate to the brain, the slow rate of growth of the organism in culture, and the related need for prolonged treatment. And treatment can include the trimethoprim, sulfamethoxyl, imipenem, cephalosporins. So various antibiotics will work against Nocardia. We don't tend to see the antibiotic resistance we see with Mycobacterium tuberculosis. And because it grows much more quickly, those antibiotics generally will work. But again, while these infections are rare, if you find yourself working in a healthcare setting with patients who are immune compromised, these are things that you might need to think about. So it'll be really important for you to get a thorough and accurate patient history when you have patients come in that have infections.